pathology. After that, we'll start in phone call.
Excellent.
All right. So we can
Yes.
start. We can start by Mariam. Mariam is free. Are you ready? Just easy.
Okay, can do.
Okay. So you can read it and the question.
A 67-year-old man chronic smoke suffering from MS, upper GI endoscopic mass in the lobe of the esophagus, diagnosed edema.
Okay. All right. So we start here of diagnosis. What is this diagnosis?
Adenocarcinoma
Yeah, it is a
esophagus.
cancer. What is Barrett esophagus?
Barrett's esophagus is chronic reflux disease causes metaplastic
Metaplasia.
changes.
What is metaplasia?
Metaplasia is change in number and morphology of the cell due to chronic inflammation or chronic predisposing factor.
It is not acute because it is not infection. It is changed from fully differentiated type to other type. For example, in the lower esophagus, from stratified squamous to columnar epithelial bulbosis.
Columnar. Yes,
So it is
columnar.
from fully differentiated or well differentiated or adult type to another adult type. Okay,
Alright.
so what is dysplasia?
Dysplasia is
Dysplasia is a malignant cell, but without invasion of basement membrane. It is the early stage of carcinoma in situ.
okay.
All right. So, what is the picture of any malignant cell? What is the picture? Cellular malignancy.
So in malignant cells, multiple mitotic figure, abundant cytoplasm, and there is cellular pleomorphism and invasion of basement membrane.
All right. And it is not necessary to have invasion of basement membrane. Malignant cell can be carcinoma in situ, can be cancer, not necessary to be cancer. And the increased nuclear cytoplasmic ratio.
Yes.
So, what is the possible cause of Barrett esophagus?
Barrett's esophagus, so smoking, GERD, alcohol chronic, and then excessive stress and spicy food. Yeah.
Okay. What other type of the cancer esophagus?
Leiomyosarcoma.
Leiomyosarcoma. What else?
Stratified.
All right. Okay. So macroscopic picture, macroscopic gross anatomy of the cancer occurring in the stomach.
There might be constrictions, clefts like ulcers, and growth, which is
You mean like a mass or?
cauliflower growth, dysmorphic growth or cauliflower growth.
What is the method of spread of cancer stomach?
Cancer stomach?
Yes.
Cancer stomach.
Cancer esophagus. Sorry, cancer esophagus.
Oh, okay. Blood, lymphatic, and local spread.
What is local invade which organ?
Trachea, so fistulations.
All right. What is the prognosis of the cancer esophagus also? Good, bad.
Bad prognosis.
What mean by bad prognosis? 5-year survival.
5-year survival is, I think, less than
25, from 5 to 25. All right. So we change the topic. We speak about cancer stomach now. So what is the common country have a cancer stomach?
Japan.
Japan and South Korea. And,
Yeah, Japan and
okay.
South Korea.
What is the etiology of cancer stomach? Any predisposing factor for cancer stomach?
H. pylori infection, chronic. Then chronic H. pylori.
What you say, H. pylori is not necessary to cause a cancer. Can cause
Ulcer.
mucosa associated multi, but not necessary to have a cancer. What else?
Okay.
Spicy food can be glutamine, smoking,
Okay,
achlorohydria.
smoking, GERD, achlorohydroid. Yes. Sorry.
Okay, so how to confirm diagnosis of the cancer stomach?
Can do biopsy, upper GI scopy and biopsy.
What is biopsy mean?
Biopsy, taking a tissue sample to see the full specimen and a level of invasion into the.
What is autopsy?
Sorry?
Autopsy. What is autopsy?
Autopsy.
Autopsy is needed from dead, so biopsy is need a sample or tissue sample from living.
Okay.
Okay. All right.
Okay.
So what type of biopsy you can take it from the stomach? What we call it?
Punch biopsies.
Bunch biopsy or in surgery can be open. What method of spread of cancer stomach?
Cancer stomach can be spread by local spread,
And
direct seedling causing Krukenbergs. Then you have
what seedling you called?
Direct seedling,
What we called it?
Krukenbergs.
Krukenberg or translamic? Krukenberg is one
Translamic,
person and
yes.
translamic.
Translamic,
Okay,
translamic.
Krukenberg accepted. Okay,
Yes.
no problem. All right. So we change the topic again.
Okay.
What is the causes of peptic ulcer?
Peptic ulcer disease causes stress, spicy food, GERD, H. pylori.
What is H. pylori?
It's a spiral-shaped organism, filamentous organism, which is
It is gram what?
gram negative, filamentous, spiral-shaped.
How to diagnose?
Diagnosis is by during endoscopy, you take a sample and do a flow test, urea breath test, and you have serological test also.
Okay, this is a flow test. If you don't see it, so it is normal. Is orange become red?
Yes.
All right. So what other? How to treat H. pylori?
So it's called triple therapy. You can give metronidazole, clarithromycin combined with metronidazole, sucralfate with PPI like esomeprazole or
What does BBI mean?
proton pump inhibitors.
What is metronidazole for which organism?
Anaerobic organisms.
Okay. So what other disease can cause it by H. pylori?
So lymphoid tissue hyperplasia, mucosa associated lymphoid mold syndrome.
Okay, MALT. All right. Thank you. Okay. Okay, so I think someone asked in pathology before in cancer stomach, Dr. Nabhan, what else you asked in the exam? Okay.
Hello, Dr. Shirin.
Yes. I don't hear you, but it's okay. All right. So anyone we can start or Mariam, you can continue. We can see. All right. Okay. So can you read the scenario?
35-year-old man complained of pain in the right iliac fossa. Blood tests showed marked level of leukocytosis, diagnosed as acute appendicitis. Has a history of mitral valve replacement for rheumatic heart.
Okay, so first question, what is the problem you can face during surgery in this patient because of the mitral valve replacement?
So could have arrhythmias.
Could have what?
Arrhythmia.
No, we speak about from surgical point of view, not from it is not cardiothoracic station or cardiac. It is not physiology, it is pathology.
Okay.
So what complication or risk you can face it because of this situation?
This DVT.
No, I mean that what is the problem you can expect it during surgery?
Pain, right? Like in like appendicitis surgery, like.
Okay, so we have three problems in surgery: patient with oral anticoagulant,
bleeding, and
infective endocarditis, and diasthermy. All right, so we started by infective endocarditis. What is the causes of infective endocarditis?
Staph viridans, aureus, and fungal infections.
Fungus infection.
Yes.
Can you see this picture?
Yes.
This is extension, we call it hyphae. Usually we show you the picture and remember that it is fungus infection.
Fungus.
All right. So what is the hand manifestation of infective endocarditis?
So there is a splinter hemorrhages in the nail, Janeway lesions, and Osler's nodules in the subcutaneous.
Okay. So what is the cause of rheumatic heart disease? Why is the patient have sore throat and have heart problem?
So auto antibodies production against in response to infection with the previously mentioned organisms, there's seedling and deposits of when they are reinfected, there's seedling and deposits. in
Okay.
the
So
cells.
what is the risk factors cause infective endocarditis? Other causes of infective endocarditis in the heart? Yes.
Tooth infected teeth extraction.
No. I mean that which heart is
Oh.
liable to have infective endocarditis?
So yeah,
It is like heart have congenital heart disease.
rheumatic heart diseases. Then any
Artificial heart valve.
Yes, artificial valves, congenital defect. Sorry.
And nowadays we have the cardiac implant, something we call it intra-defibrillator implant.
Yes.
Of course, in the past you have rheumatic heart. What is the complication of infective endocarditis?
Heart failure, arrhythmias, and your embolisms. They are more prone to embolisms.
What type of matching in the heart transplantation?
HLA and ABO antibody.
What is usually the lung and heart transplantation indication in UK? Heart and lung transplantation in United
I'm
Kingdom.
not sure this.
Cystic fibrosis. All right. Okay. So what is the complication of immunosuppressive agent you give it during transplantation? Just the heading.
So complications will be domain diseases like tuberculosis can flare up. Then
you mean opportunistic infection?
Yes.
Okay. What else?
Then
what is the common drug used as immunosuppressant?
Corticosteroid. So steroid.
What is the complication of corticosteroid?
So your
can cause
gain, flushing, then Addisonian crisis. If
what is the common is high blood sugar and the effect on the healing.
Cushing's and
Cushingoid and all
yes,
this.
yes.
All right. Of course, we have opportunistic infection. We have some tumors. Yes. What type of diastema used in this patient because of the valve?
Bipolar.
Where you put a patient bleeding bipolar diastema?
Bipolar, you don't need to actually put a patient plate because both the plates are adjacent to each other in the device.
Okay, all right. So how to avoid bleeding from oral anticoagulant in this patient?
So fresh frozen plasma if it is an emergency.
Stop the medication, stop the oral anticoagulant, and
if it is an emergency medication and don't have enough time for weaning, then you give fresh frozen plasma during or prothrombin concentrate.
Okay, what is your guide for this medication?
INR.
What does INR mean?
International normalization ratio.
It is ratio between what?
Prothrombin time of the patient and the control.
What is the normal prothrombin time?
So it has to be less than 1.5, I think.
No, it is 15. 15 what?
Okay. 15
seconds.
IU. Is it?
15 seconds. 15 seconds.
15 seconds. Okay, sorry.
15 seconds.
Oh, okay. 15 seconds.
Okay. All right. So which clotting pathway is affected by oral anticoagulant?
Common pathway.
Of course, common for all, but common and
extremes.
What is the factor? Factor 2 and
2, 7, protein C.
2, 7, 9, 10, protein S and C.
Yes. Okay.
What is the mechanism of action of heparin?
So antithrombin 3 inhibition.
Which pathway?
Heparin is intrinsic.
Intrinsic and common pathway. What is the antidote of heparin?
Protamine sulfate.
Why have to follow up it?
APTT.
What does APTT mean?
Activated partial thromboplastin time.
All right. Okay. So what is Clexane?
Clexane is oral route.
Not subcutaneous.
Yeah, oral.
Clexane is low molecular weight heparin.
Okay, low molecular.
So what is the route?
Subcutaneous, sorry.
And what is the dose?
So we give around
it is 1 milli per kilogram body weight.
1.7 milligram per kg.
No, 1 milligram per kilogram per kg subcutaneous as a prophylaxis per day and twice per day it is therapeutic.
Therapeutic.
Okay. I have another drug doses. It is an international unit. Okay. As you see, if you know some, you don't know something, but overall is good.
Okay.
All right.
Okay, Prof.
Okay. So anyone for the next scenario? This is the last scenario. No, we have two
Dr.
scenarios.
Corollos,
Okay.
do you like to jump in?
Anyone?
I'm here, Dr.
Dr.
Shireen,
Okay.
you
Nabhan?
can hear me?
Yes.
Yeah, here.
Yes.
Yeah.
Okay, go ahead.
Okay. So can you read it? You can see it? You can read it?
Yes, I can see it, yes.
Okay. So this is 45 years old woman, tennis trainer, complaint of pigment skin lesion in her right thigh. Histopathology of excised lesion proved to be melanoma. Okay. So this is melanoma. What type melanoma you know?
I know the follicular type.
Say again.
The follicular type.
What else?
Uh,
Melanoma is 5 types. It is superficial spreading, nodular, lentigo-maligna, and lentigo-melina, and amelanotic. All right.
okay.
Okay. What is the common site of melanoma in general?
In the limbs, upper limbs and lower limbs.
Yeah, you mean skin. Apart from the skin, can melanoma occur in any part of body?
In
Can occur in eye, for example, anus, esophagus. So melanoma can occur in skin, in eye, in anal, in vulva, in esophagus, and subangle, mean underneath. Okay, so what is the predisposing factor of melanoma?
I think it's genetic. For the patient
Not
who
genetic.
having
Not genetic. It is sun exposure. What else?
red hair.
You mean freckle people or people have a freckle? Freckle is a character usually common in Irish people. So predisposing factor, you see the screen or I need to share, by the way?
Yes, I can see it.
Okay, so predisposing factor is sun exposure, dysplastic junction nevus, xeroderma pigmentosa, and the freckle. Okay, so after that, how to stage melanomas?
By breath flow spacing.
We have Clark level and the Breslow stage. What is the extreme for Breslow station? Like what is good, what is bad?
The deeper the invasion, the better the melanoma.
What you mean by deeper? So the deeper is 3.5 milli, so less than half centimeter, bad prognosis, and the good prognosis superficial 0.78 millimeter, good prognosis, and 98% 5-year survival. Clark level is 5 level. What is level 1? What is level 2?
I think when it's level 1, so it's a good prognosis, and level 5, it's bad prognosis.
Yeah, level 1 is in epidermis and level 5 in subcutaneous. Okay, so which melanoma is bad prognosis? Which type of this melanoma is bad prognosis? We have many types of melanoma. Which one is bad prognosis?
The nodular type have the worst prognosis.
Say again?
The nodular type.
Nodular type, okay, and amelanotic because difficult to be diagnosis. All right. So which melanoma is good prognosis from this list?
This list?
From superficial spreading, nodular, lentigo, amelanotic, which one is good prognosis?
Superficial spreading.
Superficial, okay. So logic to be superficial. All right. So what is the method of spread of melanoma?
Local invasion.
Local, we call it satellite, lymphatic, and the blood. What is the origin of melanoma? Original cell.
From the melanocytes.
Okay, so what is the macroscopic picture of melanomas under microscope?
Area
a common question because any cell, malignant cell under microscope, it is the same. What is the character of malignancy?
Pleomorphism.
Yes. Increased nuclear cytoplasmic ratio, increased mitotic figure, polymorphism. At the end, it is abnormal melanocyte. How to treat melanoma?
By excision.
Excision and
safety margin,
usually safety margin, how many centi? Minimum.
3 centimeters.
No, 3 centimeter is impossible in the face. Of course,
I mean, it's 1 centimeter, it's 1 millimeter melanoma.
say again.
If it's 1 millimeter melanoma, so the 60 margin will be 1 centimeter.
Okay, all right. All right. So, what other malignant skin tumors you know?
Originate from the skin?
Yes. We have basal, we have squamous, of course you have melanoma. What is the origin of basal cell carcinoma?
From the epithelioid cells.
From basal cell. Epithelioid cell is granuloma, from basal layer. Okay. So what is the method of spread of basal cell carcinoma?
Local invasion, but doesn't invade
local invasion because it is locally malignant. Okay, good. After that, what is the common site of the basal cell carcinoma?
Usually occurs at some exposed area like face and hands.
Yeah, what is the common site of the face? It is a line from tragus and angle of the mouth. Okay. So we have a squamous cell carcinoma. What is the predisposing factor for squamous cell carcinoma or causes for squamous cell carcinoma?
Sun exposure, chronic irritation.
Chronic. What is in the leg? Can squamous cell carcinoma occur in the leg after what?
Yes, occur in the leg.
After what? What lesion occur in the leg followed by or can be followed by squamous cell carcinoma? Long-standing venous ulcer. What changed? What we call it margarine ulcer. All right. Okay. So mesospirito of squamous cell carcinoma.
Through lymphatic and
blood direct lymphatic. Okay. I show you the picture and just tell me what is this.
basal cell carcinoma.
No. It is the patient, it is not basal cell carcinoma. It is benign lesion. What it could be?
This
is something called keratocarcinoma. Keratocarcinoma is a benign skin tumor. You can find keratin in the center and the edge is not everted. It is like two circles around each other. Okay? By the way, skin tumor is very important because it is common in England. So you need to know melanomas, you need to know basal, you need to know squamous, and the very common station in between. The same like infective endocarditis, also one of the common stations. Okay, the next about thyroid. Are you ready or happy to have a thyroid or what you need? Okay. We have a 25-year-old woman complained of goiter and performed light hemothyroidectomy. Histopathology of excised mass proved to be papillary thyroid carcinoma. So anyone or Dr. Nabhan again, up to you.
Dr. Abdurrahman Al-Jahad, do you like to take the thyroid station? Okay, go ahead.
Okay. So this patient is proved to be papillary thyroid carcinoma. It is appear after histopathology. What is the next station, next step?
After thyroidectomy and histopathology?
Histopathology, it is papillary thyroid carcinoma. The patient comes to you in the clinic with papillary thyroid carcinoma after right hemicolectomy. And you found it is papillary. She is 25 years old. What is the next step?
Tumor malignancy workup and staging of the tumor.
No, already you have a surgery done. This patient come to you after you did right hemothyroidectomy and the result come to you papillary thyroid carcinoma. So what you need to do now?
I don't know.
Okay, is any surgery you need to offer or chemotherapy or radioactive iodine? What you choose?
According to
Increase
the
active iodine will be
stage
offered
of
for the patient.
Okay. Anyone? Actually,
I think
medullary thyroid carcinoma is
radioactive
not focal.
Can I?
This is the only cancer you need thyroidectomy. So this patient must have completion.
Completion thyroidectomy with neck dissection.
Okay. So his patient need completion thyroidectomy. What other tumor, thyroid tumor you know?
follicular, medullary, and anaplastic, and lymphomas.
Okay, which one is common?
Papillary.
What is the method of spread of each?
Papillary is lymphatic, lymphatics.
Yes.
Follicular through blood.
Okay.
Anaplastic local invasion.
Yes.
Medullary
medullary also the same. Okay. What is the origin of medullary thyroid carcinoma?
parafollicular cells.
Parafollicular cell. What is MEN 1 and MEN 2? Multiple endocrine neoplasm 1 and 2. What is this?
Disease.
What it mean? Multiple.
Autosomal dominant disease characterized by
No, it is not autosomal dominant. Autosomal dominant is 2. We just need to know. Okay.
Pancreatic combination of pancreatic tumor, pituitary adenoma, and parathyroid hyperplasia.
And the pituitary adenoma. All are adenomas or hyperplasia. What is multiple endocrine neoplasm type 2?
Medullary thyroid carcinoma.
Yes.
Parathyroid
adenoma and phagocytoma. What is the tumor marker of medullary thyroid carcinoma?
Calcitonin.
What is the tumor marker of pheochromocytoma?
VMA, vinyl mandelic acid.
Where? In which organ?
In urine.
Yes, in urine. Can lymphoma occur in thyroid?
Yes, lymphoma can occur in thyroid.
After Hashimoto. So must be after Hashimoto. All right. What is Hashimoto disease?
Autoimmune thyroiditis.
Thyroiditis, usually painful. In Hashimoto disease, the thyroid function is high or low or both?
First high, then low.
Okay. What is the value of ultrasound in thyroid swelling?
To differentiate between cystic masses and hard masses.
And solid. And see the lymph node. If it is cystic, what you will do?
Fine needle aspiration cytology.
Fine needle aspiration cytology, you know all the tumor except what?
Follicular.
Follicular adenoma and adenocarcinoma. What is the effect of external laryngeal nerve injury, which is the branch from superior laryngeal nerve?
Cause paralysis of cricothyroid muscle and loss of high-pitched voice.
All right, good. So the muscle is cricothyroid muscle. What is the cause of sudden increase in thyroid cyst?
Bleeding in the cyst.
Bleeding or can be tumor, but usually bleeding. Can be linear change, but usually bleeding. What is Graves' disease?
Graves' disease.
It is thyrotoxicosis, and it can be primary and it can be secondary. What is the difference between primary and secondary?
I don't remember.
If the patient has thyroid swelling and become toxic, we call it secondary. If patient have no thyroid swelling and start by thyrotoxicosis, we call it primary thyrotoxicosis. Okay, we show you this is Hashimoto, but we show you this picture. This is picture of one of the thyroid tumor. What it could be?
Papillary
yes, it's papillary carcinoma because empty nucleus and micro calcification. Micro calcification we call this Mumma body, and the empty nucleus we called it orphan Annie or empty nucleus. Okay, orphan Annie. This is again Malish. Okay. I start by phone call. So this is pathology. You can see in the term of pathology, usually it is fast term, and he asks you a lot of question. Is about 20 question or 90 question in short time. So the term is faster and the question is dependent on each other. Okay. This is have a phone call. Now we have any question about pathology before we start in phone call? Any question? I think Dr. Nabhan, you have gastric cancer before. What they ask you in this cancer, stomach cancer, in the exam?
Yes, I had gastric cancer. He asked
Yes.
about what are the sites of other types of gastric cancer, what are the predisposing factors, and what are the family and individual criteria.
Okay. So it is just a common question. Nothing you found it is strange.
Yes, it was usual questions.
All right. Okay. This is common, although it is not the common cancer in UK. Cancer colon is common, but usually we ask about cancer in pathology. We have two stations in pathology. One can be a cancer. Second, it can be something like infective endocarditis, and mainly from a practical point of view. Now we start the phone call. So I show you the script first. You can see a 75-old lady with a background of chronic obstructive airway disease, mild left ventricular failure, underwent mastectomy, axillary clearance for breast 2 days ago by Mr. Brown. Mr. Brown is a consultant. Post-operative, she developed axillary discomfort, shortening of breath, half a liter of blood come from the suction drain. The patient is due to go to home, but because the complication and this big amount of blood or seroma, so we postpone. Her daughter want to take her home. This is very common, and usually in the scenario or the script, they mention that this is patient or her daughter is away from the hospital about 60 miles, which is 100 kilo, and she is live in the countryside. And she is working, her husband is working, and even children is go to school. So in the morning, this patient will be alone, and in this countryside is not much hospital facility. This is what we call it bungalow or countryside, small house, or called coach, or have some something like countryside, like village or rural area. Okay, so anyone can start?
Good evening, Dr. Shireen. I can start.
Okay, can. All right, so you can start first. Good morning. So I am, can you introduce yourself? Whatever the name, just your name.
I'm Dr. Krolos, ST1, and I'm talking to today consultant about Mr.
Yes, I am Dr. Wolverson. Yes.
Mr. Wolfson, and I'm talking to you about the patient who has mastectomy for 2 days, and he.
This is my patient.
Okay, I'm sorry. And he has now developed 5 million.
No, it is my patient. Is this patient is my patient?
No, it's not your patient. It's Mr. Brow's patient.
Mr. Brow's patient. So why you call me?
Yes, I call you about because of this patient developed now.
No, why you call me? Although it is the Mr. Brow's patient.
Because Mr. Brow is not on call today. I see your name on the
call
list.
So you saw in the beginning, Dr. Corollos, you need to tell him. So good morning. Shall I speak to Mr. Wilson, the consultant in charge today, or something? So from the beginning, you need to tell him I speak to you about patient, and this patient is one of Mr. Brow's patient, but I speak to you because you are in call today. All right. So this is the beginning. After that, okay, good. What else you need to tell me?
This patient developed after mastectomy and axillary clearance. He has now a seroma and 500 milliliter
seroma.
in the
Okay,
drain.
what is
Yes.
seroma?
Seroma, it's blood. It's like hematoma, and it's blood collection.
So
in
what is the cause of this?
Maybe surgical site infection or trauma because
No,
of,
this is, you mentioned it is 2 days ago, so surgical site infection is too early.
it's due to stasis of the blood.
Yeah, so can be hemorrhage, and become serum, can, no problem. Just by bleeding and connected because it's reach 500. What else?
It's due to
Okay, so can you tell me about the hemorrhage? What your plan for this hemorrhage first?
I will support the patient by 2 wide bore cannula, and I start fluid challenge, and after this I will make blood. I will take a blood sample for blood test.
What is the indication of blood transfusion in your hospital?
If the patient hemoglobin is less than 7, I will less than 8, I will start. I will start blood transfusion.
What they will do?
I will give him 1.5 liter crystalloid. After this, if he not hemodynamically stable, I will start.
What else you need to follow or observe?
Sorry?
What else you need to observe?
I need to observe the drain.
Amount of bleeding, amount of from the
Yes.
drain. Okay, all right. Okay, so you mentioned this patient have shorting of breath. Okay.
Yes.
So can be
Yes.
chest infection.
Can be a chest infection. Yes.
So what you will do for that?
I will make culture and sensitivity, and I will start before this broad spectrum antibiotic, and after the culture I will be specific antibiotic for this organism.
So I think in our hospital we have a chest specialist or not?
Yes, I will involve
Okay,
him.
so you can ask him help. This case can be pulmonary embolism.
No, because pulmonary embolism after 5 days.
10 days. DBT can be 5 days, but pulmonary embolism 10 days. Can pulmonary embolism occur early in some case, not in this case?
Sorry?
Can pulmonary embolism occur in some patient, not in this patient, early, like after 3 days, can occur?
Yes, can.
Which cases can pulmonary embolism or fat embolism in the pulmonary artery occur? Which patient? Which type of surgery can have it? So which type of surgery can cause that?
Bone operation or medullary nail, intramedullary nail.
You mean orthopedic operation? Okay, all right. I agree. So how to diagnose usually pulmonary embolism?
By CT angio.
What type of CT? CT, you need pulmonary CT. Okay, what
Yes.
else? Okay, and also clinical and observe the patient. All right, I just show you the picture, just it is a normal, just to see the pulmonary artery. All right, back to your patient. So now the patient, her daughter need to leave the hospital. What is your opinion?
I recommend it for her not leaving hospital because she might has a bleeding, and it's important to stay under
What else against your opinion? Don't leave the hospital.
What else?
Apart from medical cause, what else you are against to discharge the patient?
Because she is in countryside, and this is maybe a developed infection. And
no, it's a countryside and away from a hospital. Forget this infection. Yes. All right. So if her daughter, you speak to her daughter, if she is still refused, what shall you do?
I will tell her about complication of leaving hospital, and this is endanger mother life. And after this, I will.
If she insisted, what you will do?
Yes, she will sign the DAMA, and after this, I will.
What
tell
is
her
DAMA
about,
mean? What is it?
Discharge against medical advice, and I will tell her about warning sign, and she should back.
What else you need to give the patient if she insisted to leave the hospital? She will sign the consent form, and after that,
I will tell her
what
about
else
warning
you need to
sign.
explain to the patient?
Warning sign, like if she has chest breathing not good, if she has hemorrhage, if she
No,
is
she is
dizzy.
not a doctor. You can do that, but what else it is important to tell the patient?
To come back if any problem happen with her.
All right, what else? But it is 100 kilos so far. So what else?
She should review her GB,
Yes?
and if something like she should call ambulance or.
Okay, so you can give her the nearby hospital or the nearby GP telephone just in case. All right. Okay. All right. So okay, finish or not yet, or what we will do? What else
So
we need to do?
the patient is yes, I will summarize. The patient has 2-day post mastectomy, and he has axillary lymph node clearance. After this, he developed a seroma.
No, it is not important to repeat this sentence. It is important to summarize what is shall we do?
Yes. Okay. Sorry. I will make the patient. I will tell the patient CT.
Okay, if this patient, I tell you, doctor, if this patient insisted to be discharged against medical advice, so she will sign a consent, and I try to keep the patient, but if she refuses, so I will sign consent discharge against medical advice. That's it. We don't start the history from the back. After that,
I will tell her warning sign, and she should come back if anything.
Okay, this is finished.
I will give her. I will make
No,
sure she
what
has.
else in the conversation you need to do?
Thank you, doctor.
Okay,
And,
thank you. Terima kasih means thank you in Malay. So summarize and thank you. Okay.
Just
Okay.
a quick advice to Carlos, because I know the practice in Egypt, they don't speak to the consultant in a concise way. So my advice, when we put a mark on a history station, we want you to be, number one, clear what you want, able to grab important points of the patient, and be able to give a good summary. And they always forget, when you greet the consultant, can I have 5 minutes of your time? You ask for permission, and this make a very good ground for you that you are a polite doctor, you know how to speak to. And secondly, you thank him at the end, which are always missed by doctor. And you must avoid hesitation. So what I will do, you need to think about it, maybe 5 seconds, and say exactly this is what you do. So this station is how professional you are, because there is a huge amount of problem happen when a young doctor in United Kingdom spoke to the GP or the patient with exactly this scenario, and he make a big problem. So what he wants you to know is that you are safe. You know which consultant you are speaking to. You took permission 5 minutes of his time. You thanked him at the end. You have a clear vision what you want to do. If the patient is risky, you will explain the risk. Then you need to sign DAMA, which is important to mention, but you cannot prevent the patient, the daughter, from taking the patient away. You must realize this. But although she did not follow your advice, you still very helpful. You give her what are the warning sign, how far the distance, please contact your GP. It will be nice as well. Call me if there is any problem. This will give you some empathy, although patient is against your advice. This combination is not easy. You need to train yourself a lot, and that's why Professor Shireen was pulling you toward the professionalism. What you will do? What is your aim? What if she done so? You notice that Professor Shireen direct, short question with a target of your clear answer. So I wish everyone will try this station multiple times to get the top notch of this station. Thank you very much, Professor Shireen.
All right, thank you. Of course, this is repeated station, but usually what we repeated, usually it means that the student performance is not good, so why we repeat it? Okay. This is also, we discussed it before, it is about 35 years old man, RTA, road traffic accident, blood pressure is 100/80, Glasgow scale 14/15, with left hemothorax, fracture left femur. You can put a chest tube, drain 200 fresh blood at time of insertion, followed by 200 second hour, and the same in the third hour. You are the cardiothoracic consultant, refer to polytraumatized patient, his unit. So anyone can start.
Yeah, I
Dr.
can, but
Nabhan?
if you may.
Okay, go ahead, Nabhan.
Yes.
Good luck.
All right. Okay. You can start.
Okay. Good evening. My name is Dr. Mohammed Nabhan. I'm CT1,
Yes.
surgical doctor. May I confirm that I'm speaking to the cardiothoracic consultant?
Yes, I am the cardiothoracic consultant in call today.
Okay, thank you. May I take 5 minutes of your time, please?
Okay, can.
Excellent.
All right.
Okay, I'm calling to refer to take your advice about a patient came to the AI having hemothorax. Chest tube was inserted, and 200 milliliters of blood was drawing in successive 3 hours. So it's a
Okay.
total of
So it's the total 600 now.
yes, the total is 600.
Okay.
The patient is hypotensive and the Glasgow scale is 14/15 with fracture left femur.
All right.
So you didn't
So
mention
what
what
is
you want from him. Okay, you tell him
what you need
what
to do.
happened. So what do you want from him? This must be clear but you're better for taking permission 5 minutes. You mentioned the scenario patient and then you put your question, and it should be properly put because this is cardiothoracic. Okay, go ahead.
Okay. So why you call him?
Okay. There is a fresh blood coming out from the patient, so that might be
So you call
It
me.
might be,
You
I mean-
need me to come to the hospital, or can I see the patient tomorrow? What you need from me exactly?
yeah, it's urgent as there is fresh blood coming out in the
So
chest tube.
you need me to come to the hospital.
Yes, if you may.
All right. Okay. So can you tell me? This is in the again. Just tell me. I need you to come. How to tell this?
Okay, the patient.
No,
is
we
having
explain to
200
the patient, but you need me
okay.
to come.
Yes, it's emergency for the patient.
So you
The
prepare the
patient having-
theater, for example, you tell the anesthesia.
Okay, I will try to check that and I will back to
No,
you.
you do that before you call me. Okay? So the
okay.
first, we rephrase it again. So doctor, I think this is indication of thoracotomy, and I call the theater, and also I contact the anesthesia in charge or anesthesia in duty, because we need you in the for this patient for urgent thoracotomy. So what is the indication of thoracotomy in this patient? Or what the indication of thoracotomy in general?
If the patient is withdrawing, if the patient is withdrawing 200 milliliters of fresh blood in each hour,
for 3
so if
successive
it's-
hour, or
yeah, if it's I think have meters.
if you insert the chest
after the-
tube, and what amount can come in the same time, it is indication of thoracotomy from the first puncture.
500.
No, 1.5 liter. If you insert
Okay.
chest tube and 1.5 liter come out, it is indication of thoracotomy. If you have 200 for 3 successive hours, is indication of thoracotomy. All right. Okay. So can make it one by one now. So All right. Can this case is ascending aortic rupture, for example?
Yes, it can.
It can. So if it can, how to see it? How to diagnose?
Yeah, we'll do issued X-ray, and issued X-ray there is a wide mediastinum, so
What
it might.
is mediastinum? Okay. So what is step done in the patient since he came to the hospital? Can you tell me about that?
Yeah, we started with ABCD approach. We checked his airway.
How to check airway? How you check airway?
The patient was talking, so the airway was clear.
All right. Okay. After that, you check breathing. It is
Yeah,
normal.
we checked breathing. Yeah,
Can
he had.
in this patient or not?
Again, please.
Can be tension pneumothorax?
It can, yes, but the patient didn't.
It's not tension pneumothorax, because if tension pneumothorax we mention to you, it is tension pneumothorax. We don't mention, so it is not. So what is the tension pneumothorax cause? What is the position of trachea in tension pneumothorax?
Yeah, the trachea will be directed to the opposite side, and there will be diminished air entry to the same side.
Okay, so we don't mention in the script, we don't mention the patient hyperresonant or all this, so it is not tension pneumothorax. Okay, after that you make AB. What is C?
Yeah, C is circulation. Starting with the.
Okay. You did?
Yes, starting with the stop any source of bleeding, giving the patient a 2-pore cannula. Which is
cannula, yes.
Yeah. Starts with fluid resuscitation and preparing for packed RBCs with drawn CBCs and INR and baseline ABG for the patient.
Why you insert chest tube?
As the patient struggle to breathe as he's having a hemothorax.
Okay, where you insert it?
In
what
the
side?
fifth intercostal space, mid-axillary line.
Okay, so what else you make it till in this period before you call me? You prepare blood, of course.
Yes, prepare for units of blood RBCs.
And you mentioned is the patient have fracture in femur.
Yes.
Yeah, can you tell me this is serious, this is important, what you are looking for in this fracture left femur?
Yeah, if the patient have a fracture left femur, he might have a pulmonary embolism by
If might have, he tell you, but what you will do? You check
I will check the pulse doing Doppler for the patient.
Which pulse you check?
Distal pulsations.
So why you check distal pulsation?
And that it might be disturbed by the fracture.
So, but in this patient is okay. What else you need to do? Because now it is not suitable to have orthopedic fixation. So what the orthopedic did for him?
They might put a Thomas frame.
They might put or they put already. They must put what?
Thomas Sprint. I say might because I didn't have the full informations.
Okay, all right. So they usually put a Thomas. Okay, what about the abdomen?
I did a fast scan and it was normal for the patient.
What does fast scan mean?
It's focus assisted sonography of trauma.
How many areas you put it?
At least 4 areas.
What is the 4 area?
The hepatic area, the splenic, and the pelvic area.
Okay, and epigastric area. What are you looking in the epigastric area? For right side liver injury, splenic injury, down free fluid, but what you put in the epigastric? Looking for? Traditional. No. Cardiac tamponade.
Okay.
If the patient have cardiac tamponade, what you see in the patient?
Cardiac tamponade, impending chest pain, and enlarged.
What about neck vein? Distended neck vein, muffled heart sound, and hypotension. Okay. All right. After that, you sank, and that's it. What
Should
is
I
the
summarize?
scenario? You can summarize. You can summarize. Okay.
Okay. So the patient came
No,
to
you don't
the
summarize. It is not summarize history taken. It is summarize decision. So now
okay.
to summarize, so Dr. Wilson, we are ready in the theater for thoracotomy, and I check the blood is available, and me and anesthesia, anesthetist waiting you. During this time, I check with the orthopedic to fix his limb or to put into mass sprint. Thank you.
Okay.
We
Okay.
don't
Okay.
summarize from the beginning. It is not
Yes.
summarize history taking. It is summarize our decision. Our decision, you need me to come for indication of thoracotomy because the patient have a lot of blood.
Yeah, that's
And you
clear.
prepare blood and you consult the orthopedic. If nothing like this, orthopedic can take it, but now it is under cardiothoracic or thoracic surgeon.
One of the common
Okay.
mistakes of this station, Professor Shireen, in Egypt, they think when you refer to cardiothoracic, you call the cardiothoracic, this is a problem and that's it. You shift the problem to him. In United Kingdom, it's not like this. You must have a clear idea that he needs thoracotomy with a clear indication. Not only this, but you already prepare the plan for him. Already booked theater, spoke to the anesthetist, already booked blood, and is it possible for you to come in? You are very polite. How we put a mark, we ask ourselves, do I like this to be my ST1 on call today or not? A lot of candidate does not speak to theater, doesn't speak to anesthetist, has not prepared blood because they think I have called the cardiothoracic, you do all that. Okay, so this is very important. And the point of summary, you don't need to summarize the history. You need to summarize at the end the decision that is going to be taken. And Professor Shireen is so nice, he is pulling you to the correct mark. But this one of the stations that you need to really read it once and once again and to get multiple revision by Professor Shireen. Thank you very much, Professor Shireen.
Okay. Next time we continue with phone call also Wednesday. Usually the phone call is one of the failure station, by the way.
Yes.
Not like pathology, not like anatomy. Pathology and anatomy is easy to pass.
Yes, absolutely.
Okay.
Absolutely.
Again, to summarize is not summarized from beginning. It is not history taken to summarize. If the history taken, you summarize from beginning. But here we summarize what our final decision or what we are final at.
Yeah. But I can watch their level is improving. Their level is definitely better than a month ago when we started this virtual OSCE. I like Dr. Mariam. She was very good in the pathology with a quick answer. Professor Kurollos, Abdurrahman, Muhammad Nabhan. There is definitely there is a learning curve and they are very near to the passing mark. But I want to be safe. I want to be super excellent. Super excellent. Don't be just to pass the station. Don't plan for this. You should be exquisitely good. And hopefully by repeating it, you will reach this level, not far away.
Okay. I think suddenly the internet is closed, but it's okay.
Yes, okay. I think this is the end of the station. Yes, we've been 8 minutes.
Dr. Muhammad, Shal, you are entered the exam before or not?
Hello, Dr. Shireen. I entered the exam in